Welcome back, Sports Medicine Project fans, to episode 76 of the Sports Medicine Project. Got a cracking episode, as always. Of course, it's good content coming at you today. Welcome to my co-host, Kelly Kortic. How you going, Kelly?
I'm good.
That's good.
Bit of an array of topics that we've got to discuss today because we do not have a guest. So we're just going solo
Freestyle,
or duo.
I was going to say.
Freestyle. Yeah, it is a bit freestyle, isn't it?
Yeah, no guest. I mean, I was thinking of this as we're going to talk about some of the topics and a little bit of a content page, I guess. But it's funny how much your thinking changes and the cases that present to you, how different it can be from hour to hour. Like, you can have someone come in with an Achilles tendinopathy and you've got to know everything you possibly can about tendons, everything about this person, dynamic, how to rebook them, those kind of things. And then the next hour, someone can come in for very simple heel pain or come in for simple hip pain or lower back pain.
Or if you're a physio, it can just completely change to the other limb.
Yeah, there's something above the hip. I just see half a person walking like they got the army shirt on. But you think of how much, and I've always said this to you ever since I actually met you, being a physiotherapist or a chiro or an osteo or someone that treats, I guess, the whole body, the amount of knowledge that you have to have, like, you should feel empowered by that. It's a bloody lot. You know, you think of going to a mechanic and there's no way you can know possibly everything about a car. And obviously we don't know everything about the human body, but you know, you're trying to get there every step of the way. I mean, it's a lot of information to know.
And I think that's why physios tend to find a niche probably earlier on in their career. Maybe I'm just drawing an assumption. However, I do think it seems to be that way where physios in the maybe first 5 years start to develop an interest area where they do refine their skills. And I think one of the reasons for that is because it can be really overwhelming to try and learn everything. And of course you need to have that foundation and know a little bit about everything, but it takes a lot of pressure off when you do kind of go in more one direction.
Yeah, and I guess when I was thinking of just that idea, I thought, what would be the counter to that? And I guess, and I've always been, lately, every idea I come up with, I'm trying to imagine, and I got this from a book, I'm trying to imagine another person sitting on the other end of the table trying to counter-argue, not counter-argue, but really just pick apart
from
what I say.
Other side, the other perspective.
Yeah, and to that argument it would be, or I guess to that idea, most of the conditions may behave pretty similar. Like the physiology of a tendon, yes, it differs throughout the body, but maybe the principles are generally the same. Calm it down, load it back up.
Yeah, I was thinking...
But maybe not.
I guess so. I guess the rehab is different and the activities that you're getting people back to are different. That's probably the only big thing. Why are you shaking your head?
No, I'm just excited. I just love these discussions. I mean,
Wait.
Yeah, here you go.
I was thinking that we have the luxury here of having a little bit more of a niche because...
In this house.
Well, in this town, because it's a bigger town.
Yeah, in the town.
But if you lived
in the Wild West,
you probably have to know everything.
Yeah.
Or you have to be more broad, I guess.
I'm going to try and really advocate for my profession here because I think it's bloody awesome. A lot of podiatrists that work in rural areas, and I'm sure it's similar with physio, but I think the ends of the spectrum are vastly different. Someone can come in with a very complex metatarsal stress fracture or a very complex talar dome lesion, and their next patient can be a high-risk diabetic with a wound. Like, it is unbelievable how differing the patients are when you're out rural as a podiatrist, and you've got to be well-equipped and you've got to have the knowledge. It is, yeah, we do have the luxury. And I mean, obviously on this podcast, we don't talk about wound care. I teach diabetes and wound management at the university, but I'm just not seeing it enough to talk about it. Whereas musculoskeletal stuff we see all the time, so we're confident in using examples and case studies and things like that. But what would be the equivalent in physio? Like neuro? Or like what would a rural physio see?
Maybe in private practice. But yeah, I guess if you're in the hospital, then you might be the physio on the ward who sees neuro, CP, outpatients, the whole lot. But in a private practice setting, it would be it would be just the whole body. You'd have to know it. I don't think you'd have enough people in the town, maybe in some towns, to have a niche. For example, runners. Maybe there's just not enough people to just be seeing the runners.
Yeah. From a business model, it's probably not sustainable either.
Exactly.
Yeah. Well, that was a long intro. And we wrote some stuff down. But today,
I knew this would happen. You
we're going to talk
write
about
down this big list and we get through none of it.
Now, what we're going to talk about today, a cuneiform stress reaction before a big race, Instagram post of the week, consequences of not getting images for very serious or suspected serious pathologies, the funnel of injury and pain, complex talar dome lesions, just how they present, general management. I'm presenting on them when this comes out tomorrow. If you do listen to this on the Monday, go to our Instagram page. Tomorrow, Tuesday night, 6:30, I'm presenting on stress fractures and tendons and osteochondral lesions or talar dome lesions. And then we'll also talk about confidence in the treatments you've given and how we posture it to people and patients where we're confident in what we've done. However, we may not have seen an effect, or the patient may not have seen the effect and they're possibly losing confidence.
How are you going to get through those 3 topics in an hour?
We're going Joe Rogan style, baby. We're going like 4.5 hours.
No way.
Everything's done. Presentation's basically finished.
You're going to talk it's a 4.5 hour presentation.
No, I was talking about the podcast.
Oh, no, I'm talking about your prezzo on Tuesday night.
Oh, yeah, it's gone over every time. If you're listening...
But how would you get through all those 3 topics in an hour?
Well, that's the thing. It's very much like the elevator pitch, like, hey, this is a bone stress injury, this is what we think it is, it's an imbalance of micro damage to repair.
And you just talk 500 words a minute.
These are the risk factors, red as female, that kind of thing. But general risk factors, general management principles, and kind of not things that you can't miss. Yeah, it's tricky. I presented on heel pain and forefoot conditions prior, and it went for a very long time.
I might be able to watch.
Yeah, come and watch.
I finished at 6:30.
Give me some feedback. There's a couple of memes. There's a bit of humour in there, which is good. One thing that I really it's not frustrating, but it's always hard when you're presenting and you, especially online, you say something, and because obviously everyone's muted, they don't have their video on.
No one laughs.
Well, that, but also if you ask them a question that's really important for the way in which you're presenting, like you might have an MRI and you say, hey, can anyone tell me what this is? And it just goes really silent. Like, oh yeah, I'll let everyone come off mute, and then someone will come off and on, and then two people come off and talk at the same time, and they're like, oh, well, it's a talar dome lesion on the anterior lateral part or something like that. But anyway, yeah. Anyway, and if you want to add anything onto there, but who knows?
I do want to add something onto there.
Yeah, you should have written it down. Oh yeah, and you've got some other stuff, but I didn't write that down.
No, that's okay. No, that's not what I was going to talk about. What I wanted to talk about was the Patreon.
Yeah, it's Patreon for the 80th time. Patreon. So, yeah, Kelly and I mentioned this on the podcast. So, if you feel as though there's 2 basic subscriptions, there's one channel where if you like what we do, you like the podcast, you like our Instagram, we've helped you with a patient, or we've helped you in any way at all, you can shout us a coffee, basically, which just goes to us buying coffee and sitting and creating content, which we love to do. Or you can sign up for a monthly subscription, which I think we have set at $6. So if you drink an oat cappuccino, it's less than that. But if you don't drink oat, it's going to be more. And yeah, it's Kelly and I talking about just case studies that we have seen and managed, and a lot of the things that we consider, questions that we asked ourselves. Now, they're real case studies. However, we have changed a couple of things, so they're obviously non-identifiable. We've got consent completely. And yeah, we just go through subjective, objective, what we did, why we did it, what was the outcome, what we would do different, some questions, that kind of thing.
And there's a bit of back and forth. So
it's a little bit different to the format here. It's a little bit more maybe open slather, and yeah, Kelly and I just critique each other, and why did you do this, or why did you do this many reps, this is why I sent them to this person, and that kind of thing.
The goal is to try and get you thinking as well, so we'll throw questions at you and at each other and try and pick our clinical reasoning about why we think what we're thinking and why we're testing what we're testing, and what other things we might be asking, what other things we might be testing. So it's a good reflection tool for ourselves, but it's also really great to help you guys and sort of for you to start thinking about why you do what you do and what you might do differently to us and why you think that might be effective. Yeah, so it's good.
Yeah, we'll never put any of the incredibly knowledgeable guests that we get on the podcast behind a paywall. That is certainly not the point of the podcast. And there will be, we haven't promoted it really at all other than the podcast. Got a couple of people on there. But the idea is what we get from the guests, people like Dr. Emily Rio and Dr. Richard Willey, how do we implement the stuff that we learn from there with our patients and how do we get those good outcomes? Yeah, which is good. So sign up's in our Instagram bio. We'll put it in the show notes if you want to sign up. Now, $6 is, I think it's $6 a month. Yeah. I know everyone says it's a coffee, shout out coffee, but it's, the idea behind it was we want to dedicate more time to this because it is continuing to grow and we're getting lots of great messages, which is really fun. But the impact we're having, I guess you're starting to see it slowly increase, which is awesome, and we really love that. And probably not so much from Kelly and I, a lot from you, not so much from me, but a lot from our guests. And the idea is if we can get bigger and grow more, we can start to get lots more guests as well. But the guests we've had have been incredible. It's been good. Yeah, we feel very lucky and privileged. And you guys have obviously made that possible. No one's going to come on a podcast if we get 200 listeners. It's going to be up there, in the thousands, which is good. So thank you to all the listeners.
Thank you.
Yeah. Thanks to me or thanks to the listeners?
Listeners and you, because you do most of the work, and I need to thank you for that more often than I do.
It only took 75. No, I'm only joking. But the listeners come to hear your voice. I'm the same. I just come to bounce the ideas off you. So let's, talk about this.
I want to go into this cuneiform stress reaction.
Yeah, so...
Tell me about it.
It was a case that I haven't seen many at all, and this person had been training for a race, a couple of risk factors for bone stress injuries, and they'd had a recent change in footwear to a more minimalist shoe, and they had a race coming up very soon, presented into me. And I guess with anyone that is a runner, I am now thinking, which I didn't previously, if anyone is a runner and they have something coming up in the future, I can only assume, and obviously I can get that from their questions, but I can only assume that they're upping their volume and their intensity, and you have to be concerned of a bone stress injury. I could even say before they say anything, because that could be a higher likelihood. So they presented and a vague dorsal midfoot pain. So for me, my antennas are up thinking, a possibly navicular stress reaction or some kind of bone injury, because there's not that many pathologies that present dorsally midfoot in runners. Maybe shoelace tightness, don't see many tibia tendinopathies, that kind of thing, maybe an ankle effusion. But yeah, so that sparked my antennas and all the things were there. Training had gone up, intensity had gone up, volume had gone up, changing into more minimal shoes. And
How long had they been running on it with symptoms?
3 to 4 weeks.
Oh, really? And getting worse?
One had to pull out of one run. Otherwise, it was the guys. Had to pull out of run, but it was painful on every run, but settled. So not enough to really stop from running. No night pain, nothing like that. So
and progressing throughout the run, not like that warm up.
No, it was warming up a little bit.
Oh, really?
Yeah,
Interesting.
It was warming up a little bit. But anyway, so I guess the thing for me was there wasn't much pain over the navicular, and it's a pretty open exposed spot. So you imagine where the navicular sits, just in front of, I guess if you put a line through the middle of the ankle, it sits just in front of there. And we have this area called the end spot in the navicular. And the idea is the blood flow to the foot comes down the dorsalis pedis on top. One goes left, one goes lateral, one goes medial, and the navicular sits right in the middle. So it doesn't have a good amount of blood supply. And that is the risk of it getting injured. It takes a really long time to heal. Plus it's under a lot of compressive force in the midfoot when we pronate and supinate. So no pain over the navicular, which was a little bit odd, but pain laterally. So that's different. Went out into the gym and did some functional testing straight away. One single leg hop, pain straight over the midfoot. So anyway, thinking navicular cuneiform, I was suspicious of some kind of stress reaction. Sent for an MRI and it come back with a lateral cuneiform stress reaction.
Do you think there's some sort of biomechanical thing for the cuneiform to have to get a stress reaction? Like, it's a bit of a weird one, isn't it?
Yeah.
So what?
This person had a more unique, more cavus foot type.
Okay.
But again, there's not much literature on it either, on how they respond and if there's any really risk factors. Like, it's nowhere near as common as a navicular. It's a low risk area. And it was really quite a different one. And as I always do with these cases, you seek out people, and I would encourage people to do that. You seek out people who have a lot of experience. And I actually messaged Michael Nishke and had a quick chat with him, which was great. And he'd seen plenty of them and had a chat with him. And low risk, pretty good blood supply. And so talking, and I wanted to ask you, if you had seen this in the clinic, and let's say they had a race coming up sometime soon, let's say they had a race the next day and they'd just seen you the day before, what would be your management strategy if you had conveyed that it's probably not ideal to run and you shouldn't, because there are the risk of obviously fracture and a stress fracture and things like that? What considerations would you then have for that person if they were going to do that?
Yeah, so my decision making would be around, is this a high risk site or not?
Yeah.
And I guess that's going to influence how strict I am in trying to either deter them or
And if you couldn't, because this is what I wanted to talk about. Like, these things happen to us where people have a pretty severe, nasty injury, and we know these are more likely to happen in the lead up to any kind of race, whether it be the tibial stress reaction or metatarsal.
I think it's about educating the patient about the risks involved and stating that a bone stress injury isn't really an injury that you should take lightly. It's a bigger injury. It's a more serious injury, and there certainly is a risk for competing in that race.
Yeah.
It's potentially going to get worse or fracture, and it might mean that a longer recovery afterwards. So I think it's just making them aware of those risks involved. However, that's all we can do, I think, as health professionals. I think we just need to be, as open and honest as we can, and ultimately they're going to just make a decision based off what they want to do at the end of the day.
Which is the idea behind patient-centered care, where they make their decision on their health, which they should, and that's certainly how it should be. We can only present the findings and the information. So let's say hypothetical, and I'll ask you, and then you'll ask me, what would you do management-wise? So let's say I come in, and let's say any kind of stress injury to the foot. So I come in, I've got a stress injury to a low-risk area of the foot. What would you do management-wise if I wanted to go out and run a half marathon the next day?
I don't know. I was thinking about this when you were talking about it yesterday, because if you're intervening and making their foot more comfortable, then that's almost implying that you're okay with it in some ways, don't you think?
Not at all. Like, to the person, like to me.
Yeah. Do you think?
No, not at all.
Like, if you're saying that there's lots of risks, blah, 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 but you're going to do it, okay, so let's just make your foot feel...
Yeah.
Do you think that's not implying that you're...
I don't. I think you have a duty of... You can certainly... I think you can. I'm sure you can. You can certainly refuse to give treatment. But if you have let's say you've got a navicular stress reaction, let's say when you had your shins. So let's say you were training for Gold Coast Marathon, you've got stress reactions to your shins. You come in and I say, I really don't think you should do it. And you say to me, I'm going to do it, regardless of what you say. What can I do? I'm going to say, and you obviously have to document all this as well and say, explain the risk and I wouldn't advise to do it, but
I guess you're just going to put them in a higher drop shoe, increase their cadence.
Yeah, just do as much as you can to try and reduce. Put them in some
compression socks. And
yeah, I had this happen with someone that had a stress reaction to their fifth, and they were actually going on holiday overseas for 4 weeks, and they were leaving in 2 days, and we had to just wedge the crap out of them. And these shoes, this taping, this compression, this wedge, and they come back and they were okay.
Yeah, and I guess the body's so adaptable, isn't it? Like, this is such a bad example, and I hate myself for even saying this, but, you know, you certainly heard of those miracle cases of, like, that Iron Cowboy guy, and...
Yeah, I don't like the genetic outliers because
Yeah.
it's likely they have something that... some kind of predisposition that they maybe have this ridiculously amount of bone density and people look at them like, hey, he did that, I can do this. Like
No,
David
I mean,
Roberts.
well, yeah, that's the other person. I couldn't think of his name. But they've done those big marathon runs with stress fractures and been okay.
Yeah.
Or maybe, like they seem to be now. But
if you... So you've got a cavus foot. If you would come to me and you wanted to run the next day with the midfoot stress reaction and you were going to do it anyway, I would try and put you in as stiff a shoe as possible. So something like, and cushioned as well. So something like a racing shoe that's maybe more stable.
Yeah, so that's what I was wondering about. Do you want something with like a higher drop, or do you want something that's more stable?
I think depending on your foot type, I think you want something more stable and shock attenuating. So perhaps like a Hoka Rocket X. So cushion, carbon plate in through there. So try and stiffen up that midfoot to propel you forward. And depending on, I wouldn't do it to you because I'd be worried about irritability. I would really love to give you an orthotic because it would be great to help support the midfoot and reduce that compressive force through, say, if you had the navicular. But what I would do is heel lifts, rocket shoe that's stiff, low eye tape you, cadence, and then make sure, and this is actually from Michael Nitschke's advice, make sure wherever you're running, try and run on the flat, not on the camber. So you're not running on the side, putting more stress through it.
Yeah. That's good advice. Yeah.
But
it's a tricky ethical one, though. I think I'd struggle with it.
Would you refuse to treat?
No, I don't think I would. If they were going to do it, they were going to do it. I would probably try and be more persuasive on the...
Yeah.
This is a bigger injury. It's probably not going to... Or maybe just have a conversation with them about, you know, is there any other runs coming up that you would be interested in having another crack at? Like, do you have to do this particular run in a week's time, or can we push it back a couple of months, give this a few weeks to settle down? Although that's still pretty hard to build someone back up to marathon sort of distance in that time.
Well, you imagine all the training that you did for Queenstown. If you had a stress injury a couple of days before and it was a low risk stress injury and it was a reaction and you trained for 6 months, I mean, you didn't train for 6 months, but if you did and you really loved running and you'd gone away for a holiday and you were with me who was running it, what would you do? You can see how it portrays. Like, you imagine someone training for UTMB, like one of the biggest trail races in the world.
Yeah.
You've just spent the last 2 years, thousands of dollars, lost time, missed things with family, and this injury comes and you're like, nah. I can see the perspective.
It probably, for me, it comes down to knowing how long it takes to rehab after a stress fracture or a stress reaction. It's like it's 12 months really until you're back like comfortably, confidently racing again.
Yeah.
And I just wouldn't want to risk it getting to the full fracture stage and having to go into a boot and then that return to run be even longer. Yeah. So maybe that's my bias.
Yeah, it's tricky. I mean, you can only really portray, and you have to really portray the reality and have yourself, you know, make the decision, and whatever it is, you'd probably try and say, I'd still advise against it, but if you're going to do it and you're absolutely set, this is all I can do to help. And
I think that's the best way to go.
And then following that, this is what you have to do. If you get through it, great, now we're on to let's do this.
Are you going to rescan this person after the race to see if it has progressed?
Don't know. I don't know. We'll see.
I don't know what that would change. Maybe just how much time off how much time off they have to have. And possibly. How do you think that they'll have to have a longer rest time after racing than what they would have if they didn't do it?
Yeah, of course.
Yeah.
Yeah, well, I mean, you're only assuming, like if you had a reaction to the bone, I can only assume if you're going to load it more than you ever have, it's probably going to be sore. and you're probably going to flare it up and possibly progress that. So I can only assume. But yeah, we'll see.
Yeah.
Now, Instagram post of the week. I put this in there, and you and I discussed this about it. There was a guy on Instagram. I'm not going to say his name.
Good one or bad one?
It was a bad one. Oh. And they're pretty common, these kind of posts, where it says you need to stop doing this unless you can do this. And this is in the context of running.
Yeah.
But it could be badminton, it could be walking, it could be breathing. Like, you can't do this until you can do this. And it's just not the case with any of the activities and sports that we help people get back to. There's certainly measures. You know, you should be able to hop and jump and calf raise, but if someone's already doing something, you don't need to stop to pass these arbitrary movement tasks.
And if you can't do 30 single leg calf raises, I'd say if you can do a little bit of running, you're going to get better at doing calf raises.
Yeah. Yeah.
So it is a way of loading the calves, if that's what we're talking about, or loading the hamstrings.
Yeah.
That's different to getting in the gym. And you probably will get a little bit stronger or fatigue resistant by doing it. So I don't know that you need to do some of those specific exercises to be able to run. I think running's going to strengthen the things that it's going to strengthen.
Why 30? Why not 28? Why not 20? How much weight? Like, what are you basing this off? Like, is it just, even all your experiences you've had with people, you can't put that into then saying you need to stop. Like, hey, you love doing something. It's great for your health, great for your weight loss.
Yeah.
Stop it until you can do these tasks, which might take who knows how long. Yeah. Not about it.
I think in the context of injury, if someone comes in with an Achilles tendinopathy and they're a runner and they can only do 8 single leg calf raises, then I'm looking at that as a deficit that would be worthwhile addressing.
Yeah.
But not in the context of injury. I don't think that there's any robust evidence to suggest that you need to be able to do 30 single leg calf raises to minimize the risk of a running related injury happening.
Yeah, well, but in saying that, you're like, if someone comes into the clinic with an Achilles tendinopathy and they're still running and they can only do 8 calf raises and the pain is manageable with their running, you're not going to tell them running. Yeah, you're not going to tell them to stop.
No, you wouldn't.
And even you never.
I think this post was in the context of asymptomatic people, though. It was saying,
I'm just saying like the worst end of the spectrum.
Yeah.
Like, you still wouldn't
stop them from running. Exactly.
So, yeah.
And again, this is something that we spoke to Jess Stenson about. Running is so much more than just exercise to a lot of people. Like, it's their social life, it's their mental health, it's getting outside in nature, it's all of those things. It's not just going and doing some exercise. So if you're saying that you can't do your meaningful activity, and I saw this as Tom Barton commented on that post saying something along the lines of this, but if you can't do if you're telling someone to stop doing their meaningful activity until they can do 30 single leg calf raises, I don't think that patient's going to come back and see you, to be perfectly honest.
Or they do stop,
and it takes away so many facets of their health.
Yeah, I can do these 4 things, which have some correlation to running, but then they start running again, and because they haven't run for who knows how long, 2 months, they're like, great, now I have to build back up again. Just silly. Anyway.
Wrong on a lot of levels, I think.
Yeah.
But I'd love to hear the counter to this. I'd love to hear a rebuttal, because I'm sure there's people out there that would argue against what we're saying. And I would be keen to discuss it.
Yeah, maybe we can have a running injury round table.
Yeah.
I don't think
like a panel.
I really don't think, when we try to have nuance and have these well-rounded discussions, I don't think we're on the wrong end of this. Like, I don't want to say...
We're always right.
That's what I don't want it to come out as, but I really think we're on the right end of this. And I think if you had a discussion with someone like that, I don't think they would want to do it in public.
That coach people through spinal stability, I think, say the same thing.
Yeah, and what's going to get someone's attention? This big person with some Instagram followers saying, stop.
Big person.
Yeah, I was going to say this big post, like, stop doing running unless you can do this.
Yeah.
Like, it gets people attention, and you know what you're doing. Anyway.
And we're all for strength training and resistance training and getting in the gym and loading the body, but we don't say that you have to stop running to do it.
Yeah. Or we don't say that it prevents injuries. Anyway, you wanted to talk about, what topic you've got up and running here?
What topic do I have? I only have one topic that I was going to talk about. And I thought I'd bring it up on the podcast because I was going to ask you about it anyways. And I thought that this would just be a good little conversation to have on the podcast. So in a couple of weeks, I'm doing a presentation, and I think I'm going to talk about MTSS.
Where are you doing that? At work?
For the physio meeting.
Oh, are you? How good. You're back.
I'm back.
Which one? At the Ripon or?
Yeah, it's Ripon, but I think it's just the smaller groups, not the panel, not the big scary one. No. Not for me. Just a quick case study. And what I'm thinking of talking about is MTSS and the question marks around, is it on the continuum of a bone stress injury, or is MTSS its own separate condition, its own separate pathology?
Yeah.
And what I was sort of thinking of doing with a discussion with Nikki as well was maybe comparing two different types of MTSS that I'm sure we've all seen before. And that would be like an acute flare-up of MTSS where it's just super irritable and you kind of have to stop them from running in some senses. Still vague pain, still over a 10 centimetre sort of distribution. And then there's the other type of MTSS that tends to be a little bit more persistent, and you kind of need to push through some symptoms to get them back to running or to get them feeling their capacity a little bit higher.
Yeah.
And the question marks around, like, are we dealing with two separate things here? Is one of these injuries on the bony pathology side, and is one of these injuries more of a soft tissue side? I don't know. So when you look at a graph almost of grading for bone stress injuries, grade 1 of a bone stress injury is periosteal reaction, which in my mind is medial tibial stress syndrome, or shin, exercise-induced shin pain, and shin splints, whatever you want to call it. However, is that always going to progress to a bone stress injury? I don't know.
Yeah, that's what Rich was saying as well, wasn't it?
Yes, that's what Rich was saying. And this is so these conversations is what has all these question marks around this condition for me. And I don't know the answers to it, so that's what I'm going to present on and just sort of put it to everyone and have a bit of a discussion. But I'm keen to hear your thoughts as well.
Do the same things that contribute to MTSS contribute to BSIs? Like increasing your training load, and your intensity, and other risk factors like low energy availability and hormonal factors. So do the same contributing factors, I guess you could say that with any injury, because all factors, like those three factors can contribute to Achilles tendinopathy as well.
Yeah, so I was kind of thinking.
But I imagine if they can contribute to MTSS, they can contribute to a BSI. So the only way to be able to identify that is you'd have to have thousands of people and have a diagnostic way to identify MTSS and a diagnostic way to identify BSI, which we do have thousands and thousands of people, and then follow them over enough time to see who develops what. And you'd have to look at the correlation between what's the likelihood if you have MTSS, do you then develop a BSI? And that automatically doesn't mean that the two are related, but it may mean your risk is higher, so you probably could say there's an association.
Well, and that's kind of what's out there at the moment. So again, when you look at the grading of a bone stress injury, grade 1 is periosteal reaction, which is MTSS. So therefore, if you were to continue training on it, you'd move to grade 2, which would be bony edema, right?
Right. So MTSS is a part of the spectrum.
Well, that's how you would grade a bone stress injury.
Yeah.
However, there seems to be cases where that's not particularly true, and you kind of need to run someone through a little bit of discomfort for their capacity to tolerate running improve.
Yeah.
And there is cases of MTSS. I think we've spoken about this a bit on the podcast before. There is cases of MTSS where I'll keep them running through discomfort when I'm confident that it's not like the localized point tenderness and it isn't
more diffuse.
Yeah.
I
don't know. I don't know, because previously, if you asked me this 2 years ago, I would say, no, you can't run through pain with MTSS because it is on the continuum of a bone stress injury. And if you keep running through pain, you're likely to develop a stress reaction and then it may be a stress fracture.
Yeah.
But I don't know.
It's hard because you're not dealing with, a very simple condition like plantar fasciitis or plantar heel pain or an Achilles tendon where the consequences are a little bit lower. If you, and I haven't thought about this yet, so correct me if I'm wrong, if you get it wrong, do you run the risk of then increasing their risk of getting a BSI?
Yeah, I don't know. Yeah. And so I, again, am biased as well from having a medial tibial bone stress reaction.
Did you have a reaction or a fracture?
Reaction.
Yeah.
Reaction. Can't remember what side it was on now.
Yeah.
And I thought it was MTSS for a long time. And so I would return to running after it feeling a little bit better with some hopping and then it just flare back up again. And so I finally went and got a scan and I had a stress reaction. So, and it started with vague pain. Like it was vague and then it became more localized.
That's hard because N equals 1.
Exactly. And maybe that's influencing my thoughts around this a little bit more. I don't know. It's one that I just don't understand. And maybe it's one of those ones where the more you kind of learn about it and the more you go into it, the more question marks that are raised.
Yeah. Yeah, it's hard. I mean, you don't want to get it wrong. You don't want to run someone that has this diffuse pain that might need a week or two off into a stress fracture.
The way that I think
I
of
guess
it
not
at
a
the
stress
moment,
fracture, but a severe stress injury.
the way that I think about it at the moment, is I separate them between acute flare-ups and persistent cases, I guess. If it's an acute flare-up and it's pretty irritable, they probably need a week off running just to settle it down, maybe take some anti-inflammatories, maybe wrap it in some Voltaren or something like that.
Would imaging give you a better idea?
Yeah, you can image it. It's just, do you need to image every single person that comes in with MTSS?
Yeah, no, you don't want to be doing that.
And then there's cases of people that have had, recurrent medial tibial, like medial border shin pain. And I think if you don't nudge them a little bit, then they just plateau.
Yes, I've seen those ones, the really chronic ones where they've been through multiple people and rightly so, they're worried about a little bit of pain progressing them forward. It's tricky, and it's also a bit of a battle getting someone to understand the little bit of pain is okay. But then on the other side of that, it's like, this person, they have pain and they have an injury, so it's easy for us to say, 2-3 out of 10, it's fine. But if you had pain for 10 months and it's not getting better, of course you're going to be hesitant to any pain. It's a real barrier.
Yeah, I have a triathlete at the moment that I'm rehabbing and doing her return to running programming. And for the first couple of weeks, she was getting, 3 or 4 out of 10 pain during and after her runs. But again, it was diffuse. It was moving around. And now we're almost a month into her return to running program and we've been progressing it. So she's been running for longer. Her volume's been increasing, still haven't introduced any speed. And now her pain is like a 1 out of 10 during and after. So her pain has gone down as her load has increased.
Yeah.
So I think that you need to do that sometimes.
Yeah, you do. It's no question, and we always have this debate, it's like, it's no question that you need this to happen or you need to do this. It's just like how do you better identify when's it more appropriate. Someone comes in with like night pain, it's localized, they can't hop, it's like, and then they have a stress fracture, it's like, you do this. We have an idea of what to do and why. But with these ones, it's always a little bit trickier. And you're probably guaranteed to get it wrong a couple of times. Yeah. Which kind of talks about one of the topics we mentioned at the start, I guess, having confidence in the treatments you've given.
Yeah.
This is something that I find the hardest balance with, where you want to do the right thing and you want to get someone back to what they love and get them out of pain as quickly as possible, but you have to respect healing times and soft tissue properties and physiology, and also the person in front of you isn't going to be able to do everything that you say and abide to 100% of what you give it. And also you may not give the most perfect thing. So when things aren't improving, how do you convey that confidence or perspective to the person in front of you? So as an example, for myself, someone had heel pain for like 18 months on and off, and we'd done some shockwave and some insoles and heel lifts and shoes and things like that. And then within a week, I usually see some improvement. They come back and said it's really no different. We talked about lots of things where, is the pain better in the morning? Can you do more with the same amount of pain? Does it not get as high? Does it recover quicker? All the things that they probably may not have thought of. And they're like, no, not really. So I was really confident that it was still going to improve. But you've always got to have in the back of your mind, perhaps it's not what we think it is.
My question to that, in that persistent case of plantar heel pain with 18 months down the track.
On and off. Yeah.
What physiological things and healing things are you waiting for?
Let me think about your question.
So you said you need to respect physiology and healing times. Yeah. What's still to be healed at 18 months down the track?
Well, I'm respecting, and when I say healing times, I guess 2 conversations to that. Respecting the time of the actual tissue, and then also...
What changes?
I'm assuming the sensitivity to the tissue. And the other side would be respecting the tricky aspect of pain and maybe their nervous system and their body system to pain, which I'm assuming does change.
Mm-hmm.
So this person's response to pain, respecting that.
So maybe you're changing the nervous system more than you're changing the plantar fascia.
Well, they're all connected, aren't they? And I do think you are changing the plantar fascia because you are changing something at the tissue level. You have to be, because you're not putting the same amount of stress through it. So if I give someone something soft in a heel lift to a sore heel, there's less load through the heel. But
that would be more like the peripheral sensitivity around the plantar fascia, wouldn't it? Not necessarily the plantar fascia changing.
Well, what do you mean by the plantar fascia?
So more sort of the mechanical properties of the plantar fascia.
So you mean the tissue physiology?
Yeah.
Or the cells that are confined within the plantar fascia?
Yeah, like is there anything within the plantar fascia itself that still needs to heal?
Oh, no. I don't know. Maybe there might be a tear, maybe some scar tissue has to heal. I don't know. Probably not.
I wouldn't say that 18 months down the track that would still be the case.
Yeah, but I don't know. So it could be, but it also couldn't be. So yes, you may be right, but you also could be wrong. So and my question to you then would be, how do you know that's not happening?
I think we can be confident around timeframes in acute injuries for healing.
Yeah.
I don't think we can be confident around timeframes for... I don't think there's healing that is still happening at 18 months down the track. I think that would have happened. If there was a tear, that would be healed within the first 6 weeks. 12 weeks maybe, if it was a bad one.
Could be. I don't know.
So I think at 18 months down the track, I would say that the peripheral sensitivity around the plantar fascia is...
So you're confident it's all peripheral sensitization?
And maybe some central sensitization and more poor load tolerance.
Yeah, and you're confident at all of it?
I guess that's what the discussion is, isn't it?
Yeah. Well, I don't think it is, but I could be wrong.
Yeah.
And...
Well, this is the question that we asked Ebony... Well, you asked Ebony Rio as well around what changes when a tendon moves from pain to no pain.
Yeah. Yeah.
And
it just
a lot of it is changes to your nervous system, maybe some changes to tendon stiffness.
Yeah.
Maybe some chemical changes at the level of the tendon.
Yeah. It's like, yeah, I mean, it's a good question. If someone has, and I guess the way I sometimes frame it and talk about it, very rarely, if your heel takes 100,000 steps over the course of a week, and that is the amount of pain you're having, if we have something soft around your heel and a heel lift, there should be less accumulative load over the 100,000 steps that you may take again. So we would assume that should make it feel better, because what you're telling me is it feels better when there's less stress through it, less compressive force through it.
Yeah.
So I would assume if there's a difference, there would have to be some mechanical change to the fascia because there's less stress going through it. If we're getting down to like really specific nuts and bolts.
Yeah, and that's kind of the idea of this conversation, is to just have questions around what you're actually changing, and when you're doing a treatment that's working, why is that? Is it because you're healing the plantar fascia 18 months down the track, or is it because you're temporarily shifting the load somewhere else?
Yeah, it's good. I mean, I guess that's what you portray to your patients. What are you saying that you're improving with them, and does that narrative stick with them and stay with them?
And do you need to explain that to patients if they're not really interested in it? Probably not. It's probably important that we know it, but I don't know if we need to be that scientific to patients.
Depends on the person, contextual, because some people want that information, and I think there's some people that do better with that information.
Do you think that will they ask you for that information and then you'll give it to them, or do you just get the vibe?
Well, if someone asks, why is it still sore? And like if someone says, what do you think's different now? Or what do I need to work on? What do we need to do differently? Some of those open-ended questions kind of lead around that way. I'm like, things can take a long time. If you've had pain for a long while, it means that pain generally takes a lot longer to get better. And over that period of time, we don't really have the greatest of understanding of what's going to be changing. Your plantar fascia is probably going to become stronger because they're going to give you some stuff, but also the way that you perceive the pain itself may change. But most importantly is we get you back to doing what you love and you're improving. We're not too focused on what changes. But other people are really different and they want to know specifically.
Yeah. Cool.
Yeah. What about and I guess this becomes, as you grow and become more experienced as a clinician, the consequences of not getting imaging for really serious injuries and pathologies. So, and Justin said a good quote this week where he said, no one ever got upset. No, I'm going to butcher it now. It was, no one ever got upset for being too cautious. No, he didn't say that. It was basically, no one ever got upset at you for suspecting an injury and it come back negative.
Yeah.
In the right context. So someone comes in with heel pain, you don't send everyone for a CT to rule out a calcaneal stress fracture or something like that.
Yeah.
But when all the signs and symptoms are there, the consequences of you not getting that imaging or not sending it to the right person are quite high. Even if it's negative, or even if it could be negative, you've got to send that. You've got to follow through with that. Do you find that? Like, what happens when something comes into you and you're suspecting it could be, it's unlikely, but it could be a serious injury? What process goes through your mind?
Yeah, I think that you just have to have that conversation with the person and say, look, I'm hoping that I'm wrong. However, if we miss this, the risk is really high. So we have to get this scanned, or we have to send you back to your GP for a further assessment, or to the sports doctor, whoever, to rule this out before we can be confident with our treatment. This isn't really fitting into a particular box, or there's things that are jumping out at me that put my antennas up a little bit higher, and if we don't investigate this now, then it could, the risk is just too high. Yeah. That's how I sort of approach it.
Yeah, I'm really similar. I just keep it really simple and short.
Yeah.
Say, these are the things that we need to do.
And I don't scare them unnecessarily. I just outline the importance of investigating it. I'm not going to say, like, if, for example, if I'm suspicious of a...
What about a
femoral stress fracture. Okay, let's say neck of femur stress fracture. If I'm suspicious of a neck of femur stress fracture, I'm not going to start fully going into the ins and outs of them having to have all this time off running and RED-S and all the factors that might be influencing it. I'm not going to do that until we've got the information there.
Yeah, it's funny because you really want to... Because you want them to understand the seriousness of it, because you want them to follow through. And you want, hey, and there's usually, let's say for an MRI, there's usually an out of pocket, or you've got to do all this to get a referral from the GP to see the doctor or the orthopedic surgeon. And sometimes that can be a barrier, and you've really got to sometimes say, the reality is if we miss something like this, there's a risk of this. So this is why we need to do it. But you also don't want to have them unnecessarily scared and like, oh, that was really, I feel really confronted by this person. Yeah,
exactly.
it's tricky. And you get better at it over time, and a lower tone and a lot more welcoming, and give it a bit of time and pause at the end.
And runners are easy because you just say to them that they can't run until like you get the information, so then they'll do it straight away. And
what about your online telehealth appointment?
So this is really cool. So I had a patient book in online
Pardon me.
recently from London, and I looked at their form and I was like, random London, so strange. Anyways, they found me through the podcast. So we did a podcast recently, and they just were searching in their Spotify and it came up. And I just thought that was so cool. And it made me realize how lucky we are with online programming for strength, for running, consults, rehab, to be able to, treat people and talk to people from all around the world. And probably for like remote and rural areas, that's really cool as well, because maybe sometimes, like we were talking about before, you don't have access to people that niche in a area that is important to them. So I think we're so lucky to be able to see people from all around the world and all around the country to help them with their problems. So yeah, I'm
that was really cool.
Really, that was really exciting. And I hope that space can grow further for us and for the clinic, because I do think we do a really good job at what we do, and we love helping runners and people get better, and whether it be running programming or strength programming or rehab from an injury, I do think that a lot of the time it's possible to do it via telehealth. So yeah, it's hard. It's good. That was exciting when you come home and said that. That was cool. Real cool. Cool.
Yeah, great. Well, let's end it there.
I think so. And there's a few other topics that we had contemplated talking about, but
luckily this isn't our last ever podcast.
We might have to save them for another time.
Yeah.
I think.
Sounds
maybe
good.
Tomorrow. Maybe we'll record a little quick one.
Yeah, a bit of we'll do that.
Yeah.
All right, lovely listeners. We'll talk to you all next week.
Have a lovely week.